I've just scribbled a few things down that I'll try and cover, but I've got some literature, some of my own research, and then some patient stories. So I'll try and mix it up just to try and keep you all awake at the end of the day. This is hot off the press. Some of you may have been involved in it. I don't know if you all know about it. This was actually published yesterday, and it's a very helpful guideline for lots of different things. So in critical care, it talks about cognitive impairments, it talks about rehabilitation. So there's lots of different areas that the guideline document actually covers. So it's worth having a look at it if you're not familiar with it. When you look at the literature, it's well known that people have long-term morbidity after being in intensive care or after having a traumatic injury. And intensive care patients specifically have additional problems, not just from the reason why they were in intensive care, but lots of other comorbidities that they develop, like critical illness, polyneuropathy. We see lots of people with foot drop, malnourished patients that really struggle to pick up weight after intensive care. And then this one study just looked at patients that said 63% of patients actually feel that they're worse off than other people in the community. And this is 1 year post ICU discharge, so it was still difficult for them to get back to the things they used to do. This article says, well, really, was it worth surviving? Because my life is so bad, I prefer not to be here than actually what I have to go through at the moment. And I'm going to talk through some of those stories from some of our patients that experienced something like this. We have one of the Times journalists was a cyclist and was run over, and he said, trauma wrecks your life. He's gone back to being an editor at the Times, but was really impacted by his experience. So these are some of our patients. There's Alison, she was a physio at the Royal London Hospital. She worked in intensive care and neuro. Christopher was 21 years old, cyclist, used to do triathlon. Far on your right is Daryl. He's South African. He was in the UK studying Masters in Business and Economics. Campbell and Lucy met on a Contiki tour. And then that's Mary. She's another Times journalist. And I'm going to come back and just tell you a little bit about their outcome and their stories. So before you come to ITU, before you have a traumatic injury, life is sweet, it's happy. And then within a few days, you end up looking like this, lost a lot of weight, loads of monitors, and this is a very, very stressful and scary experience for families. And often the patient doesn't even know what's going on, but family and friends find this time very traumatic. And then after discharge, there's a long road to recovery, so it takes a very long time to get back to the person and you were, but also for the family to adapt to the changes. The problem we often do is we just focus on the physical side of the person, and we don't think of all the other bits that's important for recovery. And there's actually so much we need to think about. So can we go back to work? Can we concentrate? Can we pay our mortgages? There's lots. How does it impact our ability to go to the pub after work? So loads of things get impacted after an accident or an ITU stay. So the physical aspects are important. Lots of muscle wasting. We see lots of edema because of the drugs that patients are on and organ failure. And then also people having cardiac problems, respiratory problems, which last beyond intensive care. A lot of work and research has been done in therapies, and I was on the critical care guidelines in 2009, and we tried to publish what rehab these patients need, but there was no literature at the time. So the guidelines recommended research recommendations rather than actually summarizing the evidence. And since 2009, lots more studies have been published about what is the benefit of early rehabilitation. So early rehab may be sitting on the edge of the bed, it may be that you get the patient into a wheelchair, or we may even do mobility or gait training on intensive care. And the benefit for that is that we try and prevent loss of cardiovascular fitness. So we try and maintain someone's baseline, because within a few days you can deteriorate so quickly with lots of muscle wasting that after 7 days of ventilation you potentially have lost 25 to 30% of your muscle bulk. So visible weakness is evident after just a week in an ITU. So several studies have looked at what's the benefit of early rehab. This is a landmark study that was published in 2009. It was the first randomized controlled trial study and was published in the Lancet, showing the benefits of why we actually need to rehab intensive care patients. They were on ventilators for shorter time, they reduced length of stay in hospital, and they improved quality of life. And on top of that, it was recognized, well, even just the physical fitness will have an impact on cognition. People will sleep better and they'll have less pain. So the problem is always, we talk about early rehab, but we don't talk about what is early rehab, what is the actual package that we give them. And this was a systematic review looking at what type of intervention helps these patients physically recover. And the only evidence they looked, after reviewing over 10,000 articles, they found 14 articles, and it said that physiotherapy works and exercise works, but we need to actually define what is the exercise that works and what is the specific physiotherapy, and for how long do we need to do that. But all the evidence is early on, so start early on. Oh, that was the wrong button. Now this for me was disappointing. So it's a Cochrane review published last year, and they didn't include, or they didn't find any studies that told us how to rehab this problem. And this is a big problem in lots of our patients, not just trauma. I used to work in ITU, and did clinic with Vichy, and we just see this in lots of our patients. Some studies looked at functional electrical stimulation, but for somehow this Cochrane group, I sometimes think it's an easy job because you don't find anything. You still have to go through all the 3,000 references though. So yeah, that was quite disappointing. In the UK, this is a very big study that's currently underway in Scotland. It's called the Recover Study. And Pam Ramsey is a nurse, and she's leading it. So you'll be seeing some of this results coming out, and that's looking at rehab in hospital, but also what can we do post-hospital, because they've recognized we do quite a good job while patients are in hospital, but when they leave, that's when the patients and the families really suffer. And I'm going to tell you a little bit more about this later. This is something, recognized or not, ICU delirium, hallucinations, feeling people are going to murder you. Lots of our patients experience it, but it goes unrecognized. You may try and engage with the patient, and this is all they can see. They have no idea who's talking to them, why they're there, what's going on. This specific study looked at, does trauma patients in intensive care have worse outcomes than other intensive care patients? It showed that trauma patients have a higher prevalence of ICU delirium and delusions and fear of death and feeling someone's going to hurt them. And that was associated with younger patients. They had longer length of stay in ITU and longer ventilator days with a bigger injury severity score. So all of this shows that actually our trauma patients that we may or may not know that has delirium or hallucinations, they have a worse outcome, so they experience more anxiety and more depression. And I don't know about you, but we hardly ever screen for delirium, and we hardly ever look at anxiety and depression of these patients. So it's something really we need to try and address. And I know we've tried to do that at the London quite a lot, and with hit and miss success rates. So what do we do about these patients and the problems in intensive care? This is another systematic review looking at the use of diaries. So patients and families and nurses would keep diaries. Christina Jones did a big international study on diaries. But the Cochrane review say there isn't really enough evidence to support the use of benefit or harm of diaries. But a small study describes some potential to reduce post-traumatic stress in the family members, but not necessarily the patient. So interventions are trying to improve outcome of patients and families, but none of them is shown to be specifically effective. This is another big issue that I'm passionate about, as we just don't think of cognitive problems that patients will have. And a lot of our patients that we see don't even have a head injury. It's just being in intensive care, the drugs they were on, and the shock and all that process that your body goes through can cause cognitive impairments. So when your patient tells you that I can't concentrate, I'm struggling managing my money, don't just ignore it, but try and understand it, refer them to a a neuropsychologist, talk to the GP. There are clinics. There's a head injury clinic that will see patients without head injuries, but it's few and far between. And then all of this impacts your cognitive function, then directly impacts on your emotional function. So I'm the husband and I can't earn my money, and what happens in the relationship. So it's got direct impact on family life. I think this is the last systematic review, and it just looked at what are people's quality of life like after intensive care. And this is general ITU patients with some trauma patients. There are quite a few studies. Some of the studies are really big, and so these type of patients, so ARDS patients, prolonged mechanical ventilation, then trauma and sepsis, and a lot of our trauma patients will also develop sepsis. So these patients typically have worse outcome than some of our other ITU patients. So how does it impact the family? There are ITU studies and trauma studies looking at family, but they're not very well investigated or explored, and a lot of it will be qualitative. I've included a few. These are just themes that came out of a qualitative study, so we've seen it all. Families are shocked. They don't understand what's going on. They're trying to learn what's critical illness, and then they're trying to cope while trying to adapt to the childcare and everything else that's going on. They want information, but they don't necessarily know how to process the information we provide. They want social support, and then they have this ongoing hope. They live in hope and just try and be as positive as possible. And throughout this, they have to adapt to potentially losing this family member, or they're never going to be the same again. So the family members often, we'll see in clinic, you'll see the patient is fine and they're just getting on with their life, and the family is having complete meltdown, and the kids aren't sleeping and they've got behavior problems. So it really has a big impact on families. These are two qualitative studies that try to understand. So one was face-to-face interviews, one was on the telephone, just trying to understand what do patients want, what helps them to get through critical care. They wanted to know what was going on, to try and understand it. They wanted to be with their family member, with the person in hospital. They wanted to try and provide support and care, because that gave them a sense of bonding and sense of security. So they wanted to be involved with the care. I know some of our family members are like that, some not, and you have to consider cultural differences, because some cultures would rather be hands-off, and some family members are just really scared. So it really depends on where you work. And then this study said, okay, we know our patients want information, or the family members want information, we want to support them, so how can we best support them? And this looked at what can we do to support patients, and quite surprisingly, there was giving patients or family members information helped with satisfaction, but it actually didn't help to reduce the anxiety or their stress levels. So is information, just giving people information, is that good enough? And I'll come back to that in a little while. So we do, and I'm the same, I give people lots of leaflets and talk to them, but is that going to help the anxiety with the family members, or is it just going to help make them happy with the service? So these are some of my work and some other work. This is one of the only qualitative studies on patient perception in trauma. It's done by Belinda Gabby in Australia, and she specifically looked at what did people think of the trauma system in Australia, well, in Victoria at least. And patients complained about communication, they wanted more information, but the big problem was on discharge. So again, front end we do really well, and when they leave hospital, everything falls apart. And they can't access services, there's no one they can talk to. They phone the hospital and talk to 10 different people. So it's a big problem, and I know it's a big problem for us. So part of the research I've done is we submit a lot of data to TARN that looks at probability of survival and everything else, and time to CT. And then we use ICD-10 codes to code what's wrong with our patients. In therapy, in rehab, we have something called the International Classification of Function, Disability and Health. So that looks at functional outcome of patients, how they recover. So in rehab, we try and apply this framework. And it's also coded categories. So each thing about, can you straighten your arm, can you bend your arm, each has got a different code. And the World Report on Disability recommended that we actually try and use the ICF in any type of rehab, so that we can standardize how we compare different patient populations with different diagnoses. So it looks like that. So most medical professionals will focus on that. So I've got an open fracture of my lower limb. So what's the problem? So I've been admitted and we're trying to meet our boastful criteria and everything else. So I've got a broken bone, which is my body structure. The body function of my leg is maybe to walk. So I can't walk to school, and I can't participate in important things like being a mother and carrying the kids. And then I've got stairs at home, the environmental factors, and I can't access GP services because they aren't, or rehab services because there aren't any in my area. So this is a big framework to try and say, don't just think of the injury, but think of how the injury impacts on all different aspects of the patient and their everyday life. So I'm going to run through my 2 studies. They both involve trauma patients. One was in clinic, and one was where I did some interviews, and just trying to see what do patients think, how do they recover within that framework. Because what I was trying to say, can we use this framework? Can I code the type of problems patients have? So this was in the trauma clinic, similar to the intensive care clinic. I won't bore you with the methods, but patients came over a year and a half to clinic, and I used what we call the ICF checklist to try and capture the problems, the functional problems they have. So we saw nearly 300 patients in clinic that year. Yeah, as you know, trauma, group of young people, mostly male, ISS of 13, and slightly more penetrating patients. And then basically from seeing all those patients, I could then categorize the type of problems they have. So each patient had a certain amount of problems that could be mapped onto the ICF. So typical problems of that cohort was pain was a big problem. This mental could be anything, cognitive problems, memory, attention, but can also be anxiety, depression. So that's a mixture of both cognitive and psychological issues. And then, quite surprising, skin. So lots of people had problems with scar management, healing, keloids, those type of things. Body image from scars, fasciotomies, things that we don't necessarily think of while they're inpatients. Things that they could or couldn't do at home. Lots of them, obviously, mobility problems. They're all very tired, fatigue. And then participation was things like, I used to watch my son play football. I can't do that now. I can't go to the pub. I can't. So participating in the things, or I can't drive, the things that gives us meaning. And environment was something that's not captured in any other trauma studies, and that's things like access to services, adaptations at home, equipment. So this was a surprising find in the data, just to say actually these people have lots of problems. And then I divided the cohort into blunt and penetrating. So the penetrating patients were younger, they weren't as severely injured, shorter length of stay. Well, when you looked at the type of problems that the patients have, and I think it relates to the mechanism of injury and the age group, the penetrating patients experienced more pain, so a statistical significant difference between the blunt and penetrating patients, where our penetrating patients had more problems with skin healing, body image, and emotional function, compared to the blunt patients that had more musculoskeletal problems, self-care and household. So my teenage penetrating patients don't like specific self-care or household activities. So that was interesting because we hadn't looked at that before. And then the patient interviews, it's a very long-winded process of doing qualitative research. You interview them and then you transcribe the interviews, and then each concept that the patient says you map onto a code. So by saying I get tired when I walk, tired can be linked on the ICF to fatigability, to muscle power and functions, and also to energy. So one word gives you lots of different categories, and walking has also got a separate code. So from all these interviews, I got 2,745 concepts, things that patients mentioned. So there were 35 patients in the group, and then I could link them to 388 ICF categories. So overall, there's 1,445 categories. And then 73 categories were mentioned by more than 15% of patients. And what's good about it is it shows that we can use the ICF to pick up the problems that patients experience. So I'm going to come back to these patients. So Ali was cycling home from the Royal London. She got run over. A car was doing a U-turn in a park, and she got bumped off a bicycle. As I said, she was a neurophysio, very hands-on. She sustained a spinal cord injury, incomplete C5-6. She told the paramedics to take her to the Royal London Hospital, not to her local Lewisham, because she knew the surgeons, she knew we were a trauma centre. She was in rehab for 12 months. She's one of the lucky ones because it was an incomplete injury, and she's given up physio because she doesn't have the upper limb strength and ability, and she's affected on her left side. And now she is doing research. Christopher was 21, triathlete, another cyclist, versus Laurie. Alison's, the driver, didn't get charged at all. Was nothing. No, it was just thrown out of court. Christopher, again, Laurie, he had a stoma for a long time. He's 4 years post-injury now. Stoma for a long time. We got that reversed. He's still incontinent. He's just finished his graphic design course. He's got a girlfriend, but the continence is really a struggle for him. Lucy and Campbell, like I said, they met Contiki tour, drunk night, fell off a balcony 3 weeks after they got engaged. Cameron's very mobile, but very cognitively affected, very aggressive. But Lucy's been amazing, and they're still going to get married. And then there's Daryl. Daryl was the student. He was very depressed, jumped in front of a train, had a bilateral above knee amputation, and I just happened to see him in hospital, and then happened to go home a few weeks later and did a home visit with him in South Africa. And he is playing sitting volleyball for South Africa in Paralympics. So he's done really, really well, and he hangs out with some of my good friends, and this is them playing beach volleyball in Camps Bay. And then there's a not so happy story, which is Mary. Mary was a Times journalist. I think a lot of us remember her. She was another cyclist, and she had quite a bad outcome. And Mary, this is not a photo of Mary, but she's being cared for long term, and she's minimally conscious. So all these patients and their families have lots of things have happened to them, and it's impacted. As you see, some patients have good out. Christopher looks like a normal person, but he knows he leaks and he smells, and he's very conscious of it. And the things that we don't see when we walk past patients, that emotional scars and the physical scars, is a huge impact on patients. So trying to make people's lives better, there's something called self-management, supported self-management. It's a big thing, trying to engage patients to help them to get better. So it's King's Fund priority, and also the Health Foundation. And what we try and do is to enable patients to manage their condition, so that once we aren't around, when they get home, they can look after themselves. So if you think of something, when you've accomplished something, how did you feel? So I don't know if anyone's doing London Marathon on Sunday, or, oh, really? Good luck. I've done it twice, it's enough. So how do you feel? Do you feel elated? Do you feel happy? Do you feel proud of yourself? Scared. But that's what we want in our patients. We want to make them accomplish something, because that elation, that feeling of, flip, I can actually do it, that's going to help them take the next step and not rely on us. So I learned to snowboard. I was very bad at snowboarding, I ski now. But you start on a blue run, or green run, then a blue run, and then a red run. So by doing that accomplishment, you get the courage to keep going, to keep pushing harder, to do something different. And that's what we call self-management and self-efficacy. So it's basically, what do you believe about your abilities or your capabilities, and how can that behavior change you so you can keep performing and keep changing how you recover? Because those patients, the good examples, all of these people had very high self-efficacy. For Daryl to go without legs and play volleyball, he needed a lot of drive and a lot of belief in his capabilities. So ICU Steps is a critical care charity, and they are working with us, and we've just set up this website called After Trauma. So this is specifically, these are all our patients. came for a photo shoot. And what we're trying to do is, this is for aftercare. So we're trying to say to patients, I can't be there helping you every step of the way, but the website has resources with ICU steps, and the recovery study in Scotland is going to work with us to try and get some resources out for patients and families to help with the recovery. Because we realize if we rely on statutory services, we are going to be very limited. So these patients I have mentioned, they've all given me permission to talk about them. But I just want to, so I'm hoping that you got a glimpse of the long-term problems and complications and challenges that patients and families face. And when I do long-term follow-up on the phone, and you say, I want to ask you 5 questions, and half an hour later you know about everything that's not working, then, my boss wants to know why it takes me so long to do follow-up. It's because there's a person at the end of the phone that wants to talk to someone. So there we go. Thank you very much.